TopMedTalk.
Welcome to TopMedTalk. This piece, Autonomous Systems in a Perioperative Setting, revisits a conversation we had at Anesthesiology, the annual general meeting of the American Society of Anesthesiologists. It's presented by Desiree, Chappell and Monty, Mythen, with their guest, Alexandre Joosten.
It is with pleasure I introduce our next guest, Dr. Alexandre Joosten. Alexandre, it's so nice to see you.
Yeah, thank you very much.
For those who may not know you, you're from Paris, but tell us a little bit more about yourself.
So I'm an anesthesiologist. I'm not doing any intensive care medicine now, but I graduated from Brussels, Université Libre de Bruxelles. I did 4 years as a young resident and then as a young junior faculty before joining Paris, Bicêtre and Paul Brousse Hospital now, where I do a lot of major abdominal surgery, including liver transplant surgery.
Last time we were able to talk to you and catch up with you, we had a lot of conversation around automated systems, closed loop systems. We were having that conversation about like fly-by-wire. I mean, it's a really great conversation. You can actually find it at TopMedTalk.com. It's a previous conversation from ESA. A lot has transpired since then, I think. But Monty, you want to set the stage for us just a little bit?
Well, I mean, we understand the concept. The closed loop concept has been there for a very long time. And in flying, for example, following man landing on the moon, you got the sort of fly-by-wire theory. In other words, the human being is still making the decision, but the systems are helping you to smooth out that, as opposed to a fully closed loop. Some diabetics now are using fully closed loop administration of insulin to keep their blood sugar under control. And in anesthesia, for example, we might be familiar, and I think it's happened in much of the world now, that if we want to get our vapor concentrations just right, we ask the computer in the anesthetic machine to reduce the flows as much as possible. That's sort of broadly speaking what we're talking about. Now, Alex, you've been working with colleagues, I think, on actually closing the loop with things like fluid administration, vasoactive administration, and possibly even depth of anesthesia as well. Is that right?
Yeah, in fact, in my hospital in Brussels, Luc Barvet, who is now retired, he developed in the late 90s automated system for depth of anesthesia to titrate propofol based on the BIS variable. So he did this, and it was almost standard of care in my hospital. So we had 4 or 5, we call it a toolbox. So it's a kind of trolley with computers and the monitors. He asked us if we want to use it on a day-to-day basis as an open loop. So we just have to adjust manually the concentration of the 2 drugs. Usually it was propofol and remifentanil. Or we can use it as a fully automated system. Usually it was only him, me, and maybe one other guy who did it completely automated. But we had it on a day-to-day basis. Yeah.
So let's unpack that for a second. The depth of anesthesia monitor, stickers on the forehead, we referred to it as BIS, which is one version of it. And that gives a number that people treat to say, am I giving enough or not too much, or the depth of drug. They just said, choose a BIS number, and the drugs will adjust automatically by the computer to keep the BIS number where you, the practitioner, chose the BIS number to be. Is that it? Have I got it?
Yeah, exactly. Yeah. So the clinician, in fact, has to decide for each patient what's the clinically meaningful endpoint. So for the BIS, usually it's 40 to 60, but if you have an old patient, you can even target 50 to 60, and then the system is going to titrate propofol continuously during surgery to maintain the variable in this narrow range. What is very important is that when we as clinicians, we adjust a drug, usually we do it, you can see it in all published studies, around 5 times per hour. It can be drugs like a vasopressor or hypnosis drugs.
That seems like
but
a lot,
an
actually.
automated system, usually it's more than 25. So it's almost micro-adjustment, continuous micro-adjustment, instead of we do like a bigger adjustment.
Yeah. I can see that in everyday practice. That's why I said it's actually even adjusting 5 times seemed large. It's like you have a couple blood pressures, you wait for a while, and then you adjust the rate,
Yeah, and then you have overshot, undershot.
The systems that are getting closer in the hemodynamic management world, I mean, it's fairly intuitive when one says that. You should be able to do the same with your vasopressors. On the fluid front, there is now commercially available assisted or automated fluid management with Edwards Life Sciences. That's still an open system, isn't it?
Yeah, and I think it's well appreciated, because if you try to provide to a clinician a fully automated system directly, the clinicians won't use it because today they do as they want, and if tomorrow you just tell them use a fully automated system, it's not well. So to have in between something which is just going to recommend an action, but you as a clinician have to say yes, I'm going to do it, it's still better. So it's well appreciated.
Professor Dr. Maxime Cannesson, his name and others have been associated with bringing that forward to actually become a commercially available product with Edwards Life Sciences. So that's something that's here today.
Yeah.
And that system, as I understand it, fluid is administered and then the hemodynamic changes are fed into a sort of learning form of artificial intelligence. So it suggests not only when, but how much fluid you should give next. Is that about it?
No, it's just recommend that a bolus of fluid should be given to the patient because the system believes that after the bolus is given to the patient is going to be a fluid responder.
Okay.
So it's a kind of prediction, but each time you are going to give a bolus, the system is going to learn how the system reacts, how much stroke volume increases, how much stroke volume variation decreases, and from this, the system is going to recommend more precisely. So the more the system is going to recommend the bolus, the more precise the system is going to become.
And so it may be a 500 cc bolus the first time, and then the next time it's a 250 bolus, and the next time it's like a 220 cc bolus. Does it get that?
So the system is not going to recommend any kind of fluid or amount, just that a bolus should be given.
Bolus should be given.
That's good because once again the clinician has a real input to decide which kind of what amount and what type of fluid he wants to give.
Now we'll come back to that one in a second because there's some big news in the space of what happens next with that technology, a grant that you've received, which I hope you'll share with us. If you then go to because the third component, sort of depth of anesthesia fluid vasoactives, they're all being tested and experimented on in different places around the world at the moment. We're seeing literature, much of it from you, coming through to say that is all possible.
Yeah, not only our team, but multiple teams. But it's true that in clinical practice, published in human, in surgical patient, we are, for vasopressor and fluid, among almost the only team publishing studies on this. But for depth of anesthesia, we have a lot of team performing some clinical studies. And even we have on the market 2 and nearly 3 devices widely available. One in Canada, another one in China, and soon one from Paris.
So we would say, a bit like we do with our anesthetic vapors, we would say, I want the biz to be this number, I want the map to be that number, but in keeping the map of that number, I want you, the machine, to help me to do the right thing. So if I should give fluid before vasoactive, help. If I should give pressor or inotrope, help. And it just is lane control.
Yeah, for the moment they are working completely independently. Okay. That's why it can be dangerous if you don't have a good training and also a good education in anesthesiology. Because, for example, if you use the closed loop system for vasopressor therapy, if MAP is low, the system is going to increase vasopressor all the time. But maybe it's a problem of fluid administration or depth of anesthesia. That's why the system is not going to work by itself, but just under the control of the clinicians. So it's not a human alone versus machine alone. It's always human alone, standard practice today, versus maybe in the future, the combination of human and the machine together.
Yeah.
Part of the challenge we have with algorithms and protocols is that human beings are very reluctant to follow algorithms and protocols. There's about a 50% compliance with...
Yeah, usually in published studies, it's around 50%.
Yeah.
So imagine, as I used to say, what should be the compliance without clinical condition or clinical randomized trial. So I think in real life it should be extremely low. Yeah. But in published condition, it's usually around 50%.
Do you have any more questions about that bit, Desiree? Because we've got some big news.
No, I was just going to ask. You said there was some big news. What is the big news?
Yeah, so I won a grant.
Drum roll.
I won a grant on the assisted fluid management from the French Ministry of Health. Oh. So it's an outcome study including more than 1,800 patients. We are going to conduct this in 2023 in 12 French centers and 4 to 6 outside France centers, probably in Europe and maybe in the US too. Oh. It won't be randomized controlled trials because usually when you try to assess or calculate a sample size, you take your retrospective data and you calculate it, and then you find an incidence of complication, for example, in the control group, and then you try to decrease it by a novel intervention. But usually what you observe in many big trials in New England Journal, JAMA, is that when you do a simple randomized controlled trials, the incidence of postoperative complication is always lower in the standard of care group because we are just in a study condition. So clinicians may feel that they need to be a little better than what they usually do. So we decided to move on to what we call a step-watch cluster randomized controlled trials. So it's a kind of before-after study.
Yeah.
What is going to be randomized is the moment where you are going to switch from standard of care to the new strategy. So all center is going to start with a standard of care group, and then the statistician is going, or the hospital, to call the hospital to tell the team, okay, next month you are going to start the implementation of the new strategy. So it's the monitoring of stroke volume and stroke volume variation using the hemisphere, coupled with the assisted fluid management recommendation, and this is randomized. And each center is going to start at a different moment.
Oh, okay.
What is good is that in the control group, they won't know that it's a clinical study. So the team is going to do as usual, you know.
Yeah.
So they will not be aware even that we are taking all the data after surgery.
So if we're 3 hospitals, we carry on. We start and we do what we usually do, and then Desiree gets switched on, gets the call in March, and then you get the call in May.
And that's all randomized when that happens.
This is
so
randomized.
That's why it is.
And then we know that we'll have maybe 1 week of training, and then all the future patient is going to start with the new strategy. The other thing is that with this, it's easier to recruit patient because the patient does not believe that he's randomized. There is no randomization of the patient, but a randomization of the beginning of a new strategy in the hospital. And so for the patient, it's easy. We just have to see him and just tell, can we keep your data of the surgery? And then probably we'll say, we change our strategy recently. Can we keep the data? So we expect to have a very low number of patients who can refuse to participate.
Yeah, absolutely.
But the protocol compliant, because I was involved with and we interviewed in the past about a very large step-wedge cluster randomized trial in the United Kingdom about quality improvement. Mm-hmm. And the executive summary was that the intervention didn't make a difference because nobody changed their practices. Do you think you've got a better chance? Because this is much more focused. It's AFM, so it's instructive. And it should be that the compliance rate should be meaningful.
Well, there weren't a lot. I mean, that was very complex.
It's very complex. It was very complex.
The interventions were and the things that they were doing.
I'm saying I've got great hope that this would work because it's 1 or 2 things and you've got the instruction coming from the machine as well.
Yeah, so I cannot predict what will be the compliance of the study. But what is important is that for this amount of patients, which is almost 2,000, I decided to use a small number of centers because I believe that if we just have, for example, 15 centers, they are going to recruit around 100 to 150 patients per center. I believe they will be better if they do it 2 or 3 times per week than if you have 50 centers doing just 40 patients, which means 4 patients per month, which is diluted among 40 anesthesiologists and nurse anesthetists.
The variability is just so huge there, you can't control anything. And are you going to be focusing 2 things? One, specific providers at those institutions. Will it be like a core group of people are doing it, or is it kind of random within that? Within that group.
Yeah, so I choose just colleagues when I know them, so I know I can
that
push
are
them
invested in it.
Yeah, exactly. I select because I had some colleagues. They call me because they say, "Okay, I want to participate." I say, "Okay, what's the potential recruitment of your center?" Okay, no, I'm not going to tell you to keep your center, but I just have to explain that I really want to be very focused on compliance this time. Yeah. I think assisted fluid management system is going to help. The big part will be the clinician.
What type of cases and surgeries are you going to be focusing on? Is
just very high risk abdominal surgery. Okay. But for me, abdominal include also vascular, which is aortobifemoral. Yeah. Everything which is in the abdomen can be either robotic, laparoscopic, or open, but it will be mainly pancreatic surgery, liver surgery, major liver surgery. Major urologic surgical procedure like cystectomy, like cancer debulking, like intraperitoneal chemotherapy or complex combined surgery, gastrectomy plus colorectal surgery plus surrenalectomy, etc.
Yeah.
So it will be a long surgery, probably around 6 to 7 hours.
Okay, so you're gonna not even the typical...
Yeah, because I need surgery with a lot of bleeding and fluid, because otherwise we won't see anything.
Yeah, very true.
Need a big signal.
Yeah. Wow, that is so interesting. Congratulations.
Yeah, thank you.
This is huge, and a step in a very interesting direction that we've been talking about.
Yeah, so
Maybe
maybe
we'll
we
be
can
looking for possibly some US centres which have great enthusiasts in it, won't we? So
yeah.
maybe there's one over there.
I was just going to say, we need to talk after this. North Star Anesthesia.
Exactly.
That's a lot.
So, but I really want to focus on a small amount of centers.
Yeah.
And maybe we can discuss in the next 3 years about the result of this study.
Oh, absolutely.
Yeah.
You know it. Yes.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.